Okay, class, let's take a look at cranial nerves. Let's start with some cranial reflexes. I know I've done the cranial nerves already. We did them when we focused on the different centers of the brain, right? We mentioned that we had the medulla, pons, midbrain, and then cerebellum. And the cerebellum I'm not cerebellum, cerebrum, my bad. Cerebrum was cranial nerves 1 and 2. And then the midbrain was cranial nerves 3 and 4. And then the pons was cranial nerve 5 through 7. And then the medulla was cranial nerves 8 through 12. So let's just look at some of the cranial reflexes. When we talk about a reflex, there's always going to be a sensory and a motor component to it. So when we look at the corneal reflex, this is what happens when something touches your eye. What happens is your eye blinks. So something has to sense that something touched your eye. And what does sensation to the face is the trigeminal nerve, cranial nerve 5. It has 3 divisions, V1, V2, and V3, where the V1 section is the ophthalmic branch, the V2 section is the maxillary branch, and the V3 section is the mandibular branch. So the V1, which is the ophthalmic branch, is the sensory to the eye, and then cranial nerve 7 is motor, that's efferent. And what's going to happen is when something shuts the eye, the response is you're going to blink. Okay. Let's look at the direct light reflex. You shine light into your left eye. When light shines into your left eye, cranial nerve 2, the optic nerve, has to pick up the light. That's the sensory part. When it picks up the light, cranial nerve 3, which is the oculomotor, it's going to constrict the pupil on that side. Okay. Now, the same thing is true the consensual light reflex is if I shine light into the left eye, yes, the optic nerve is going to pick that up, but it's also going to cross information over to the other eye, still the oculomotor, and you'll get constriction of the opposite pupil, the contralateral pupil as well. Okay, so those are the main reflexes there that I want you to be familiar with. We already covered cranial nerve 1 and 2 when we did the cerebrum, right? So cranial nerve 1 was olfactory, and that deals with the sense of smell. So you would hold something under the person's nose, and with their eyes closed, you would ask them if they can identify that smell. Typically, something they could recognize like cinnamon, coffee, lemon. Those are like universal scents. And you should hold it not immediately right under the nose, but let's say 5 or 6 inches underneath the nose with their mouth closed. They should be able to identify that. What current research is showing us is that if they can't, and you have to get close, 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 like almost right under the nostril, that's typically an indicator for Alzheimer's disease in the near future if they don't have that sense of smell. So, doing this type of neurological testing is really important in healthcare. Cranial nerve 2 was the optic nerve. That would be if you're standing in front of someone and you say, "Can you see my fingers?" And they say, "Yes." And then you go, "Okay, how many fingers am I holding?" And they say, "Two." So now we know, yes, they can see the fingers and they can also work on the processing of differentiating how many fingers they're holding. Okay. And with optic nerve, you can shine a light in and you want to see that pupil constrict and you want to shine the light in and make sure the other pupil constricts, right? So cranial nerve 2 is sensory for vision. Cranial nerve 3 is the oculomotor, and what cranial nerve 3 does, it does a few things. One of them is that it helps keep the eye open. So cranial nerve 3, think of the three columns that helps to keep the eye open, and it also controls the muscles of the eye. If you remember, SO4, LR6, all over 3 means that the superior oblique muscle is the fourth cranial nerve. The lateral rectus is the sixth cranial nerve. All over 3 means all the other eye muscles are going to be cranial nerve number 3. Okay, so this picture right here shows the oculomotor, cranial nerve 3. Underneath it is cranial nerve 4, the trochlear, SO4. And then you have the abducens, which is LR6, cranial nerve 6. So SO4, LR6, all over 3, all the other eye muscles are cranial nerve number 3. So we did this already. So here's cranial nerve 4. The trochlear is cranial nerve 4. It goes to the superior oblique. And then cranial nerve 6 is LR6, lateral rectus, cranial nerve 6, abducens to the lateral rectus. It abducts the eye. Cranial nerve 5 has 3 divisions. This is V1, this is V2, and down here, this is V3. Okay, so this is why the ophthalmic branch, V1, this is the sensory part to the corneal reflex. If something touches the eye, cranial nerve 5 has to sense it, and then cranial nerve 7 makes the eye blink. So cranial nerve 5 has a dermatome to the face, and cranial nerve 5 also controls the muscles of mastication. The temporalis muscle, the masseter muscle, the internal and external pterygoid. Those are the muscles of mastication, the chewing muscles. Cranial nerve 5, this is if you bite on your tongue and it hurts, that's cranial nerve 5 that's feeling it. Picking up temperature on the tongue, right? If something is hot or cold or biting your tongue, that's all trigeminal. So there's a sensory and a motor part to cranial nerve 5. When it's damaged, if there's a virus that attacks this nerve, you can actually get herpes zoster or shingles to the face that affects this. You can also get trigeminal neuralgia, which is lightning, lancinating, stabbing, shooting pain to your face. That's called trigeminal neuralgia. It's also called tic de la rue because when it hits, the person kind of grimaces and they move their entire face like a spasm, like a tick. It's called tic de la rue. There's our cranial nerve 6 again for the abducens, lateral rectus. Cranial nerve 6 moves the eye laterally, which is what the word abduction means, to move the eye away from midline or center. Here's our cranial nerve 7. 7 deals with all of the facial muscles. It's facial expression. Cranial nerve, if you remember back to cranial nerve 3, cranial nerve 3 keeps the eye open, but cranial nerve 7 shuts the eye. Just think of the number 7 with a hook. It closes the eye. Cranial nerve 3 helps to keep the eye open. If it can't and the eye droops, they call it ptosis. Ptosis is when there's cranial nerve 3 damage and you can't keep the eye open and it closes. They call it ptosis. Okay. Cranial nerve 7 closes the eye. It helps you blink. If there's cranial nerve 7 damage, you can have facial paralysis, where half your side of your face is almost expressionless. So when you smile, half your face goes up and the other half of the face does not do much. Cranial nerve 7 also deals with the tongue, where it deals with sweet, sour, and salty. So just think sweet, sour, salty 7. And it also deals with the salivary gland. So everything with S's: sweet, sour, salty, 7, salivary glands, all with S's. Cranial nerve 8, vestibulocochlear nerve. It has two divisions: a vestibular division and a cochlear division. The vestibular division deals with the vestibule, which are known as the semicircular canals. There's an anterior canal, a posterior canal, and a lateral or a horizontal canal. That deals with movement of the head, like when you tilt your head forward or tilt your head back or turn your head left and right. There's fluid in these semicircular canals that send signals to your brain to let you know where your head is. When these calcium crystals get lodged in any of these canals and they don't go back to their normal starting place, this gives people this feeling of vertigo known as BPPV, which stands for benign paroxysmal positional vertigo, meaning the person turns their head left and they get vertigo, or they're lying down in bed and when they only roll over to the right, they get vertigo. This is a predictable type of vertigo called benign paroxysmal positional vertigo. The key word is positional. It's based on the position of their head that triggers it. If it's positional, it's fixable. It doesn't take long, only a few minutes. If it's chemical, these are difficult to fix. Some of these are caused by viruses. Some vertigos are caused by medications like blood pressure medications. Some are caused by infections and they don't last very long. They can um, uh, pretty much correct themselves. But when you take a drug that's ototoxic, these could potentially do permanent damage to the ear, either to the balance center of the ear or to the cochlear portion, which is the hearing portion of the ear. A simple thing like aspirin. Someone can take an aspirin overdose, and this person can have a lifetime of tinnitus or ringing of the ears based on aspirin. There are certain drugs that are ototoxic, and you need to make sure that before you take it, it's not ototoxic, because it can create a lifelong suffering of either tinnitus or imbalance issues. So vestibulocochlear nerve is one nerve that has two divisions. A cochlear division deals with hearing, and a vestibular division that deals with balance. The glossopharyngeal, which is cranial nerve 9, deals with bitter to the posterior 1/3 of the tongue. Cranial nerve 9 also deals with the parotid gland. Cranial nerve 9 also deals with the gag reflex. So cranial nerve 9 is bitter to the posterior 1/3 of the tongue, whereas cranial nerve 7, which was the facial, was sweet, sour, salty to the anterior 2/3 of the tongue. So cranial nerve 7 deals with the sense of taste for sweet, sour, salty to the anterior 2/3 of the tongue, but cranial nerve 9 was bitter to the posterior 1/3 of the tongue. It deals with the parotid gland and also deals with the gag reflex. Cranial nerve 9 being sensory, and cranial nerve 10 being motor. So 9 has to sense that something touched the uvula, and then cranial nerve 10, the vagal nerve, makes the muscles constrict and contract. Cranial nerve 10, which is the vagus nerve, you can see that it's vagrant, It wanders to the heart, to the lungs, to the liver, to the gallbladder, to the stomach, to the intestines. It goes to like 80 to 90% of the parasympathetics, right? The parasympathetics are cranial nerves 3, 7, 9, and 10. The cranial nerves that are parasympathetic are those cranial nerves. But the vagal nerve, remember, that originates in the medulla, and that's protected by C1 and C2. And this is why there's so many people in healthcare that get a little bit confused when they hear of someone that may have a heart issue going to a chiropractor, or that may have a lung pathology that gets improvement from seeing a chiropractor, or has liver detoxification issues, or stomach acid problems, or indigestion issues. They didn't understand, like, well, they think of it as, how can cracking your back help with some of these visceral problems? But it's not about cracking a back or making a popping sound. It's about removing neurological interference in the area of the medulla that's protected by the top two vertebrae, atlas and axis, which is where the vagal nerve begins. And if there's misalignment or interference there, that's creating a blockage to the action potentials or the nerve impulses that go to the heart, or that go to the lungs, or that go to the stomach, or the gallbladder, or the liver. These parts may not function at 100% optimal. Maybe they're functioning at 70%. So if they're not functioning at full capacity, there's a degree of dysfunction. And what diseases are is putting a name on that dysfunction. So I tell people, especially, parents that have infants, that young children, that if there was a traumatic birth, or the child is having some sort of indigestion, they can't hold down a meal, there's heart arrhythmias, there's lung issues, very simple to get checked. Very simple to get that upper cervical region checked for any type of neurological compromise. That's the importance of the vagal nerve. We know that it is involved with sudden infant death syndrome, or crib death, because of the physician that did the autopsy on over 1,500 babies. He had found that there was 100% correlation in every single autopsy with what he referred to as atlantoaxial instability. And in his paper, strongly suggests that any sort of traumatic birth syndrome should always have a visit with a DC, with a doctor of chiropractic, to assess and evaluate the integrity of that upper cervical spine. The longer there's neurological compromise, the faster these things start to degenerate. In terms of cranial nerve 11, the spinoaccessory nerve, it deals with the SCM and the trapezius muscle. That's pretty much it. The sternocleidomastoid and the trapezius. Embryologically, these two muscles they're one. But as the skull develops and the clavicle elongates, they separate, and it ends up becoming two separate muscles. But they start out fused as one, and then they separate. And last but not least, we have cranial nerve 12, the hypoglossal. Cranial nerve, the word glossal means tongue. Hypo is underneath. So the hypoglossal controls the movement of the tongue, whether it's sticking out the tongue, elevating, depressing, moving the tongue side to side. When there's a thorough cranial nerve assessment, they will ask the patient, especially if they're suspicious that maybe there was a stroke within the medulla, they'll say, stick out the tongue, and the tongue should go right down the center. If it deviates left or right, strong indication of a stroke. Same thing, They'll ask the patient to say ah. They'll shine a light in the throat, look at the uvula, and it should be in the center. If it deviates side to side, strong indication of a stroke. So here's a little summary of those cranial nerves. Um, you should know their Roman numeral, you should know their name, and their primary functions.